Hello, everyone. I'm Arthur, and welcome back to our series on the cranial patient. And this is episode 2. And today we're going to be talking about the abnormal neurological exam. The first time we talked about the normal exam. This time we're going to be talking about what's usually pretty obvious, not always this exaggerated, but usually an abnormal finding is fairly easy to pick up on, be it baseline or something that's new. And that's sort of the point of this talk. And the first thing is important to know, again, to know what the normal exam is. And a hint, take a look at my first talk. I do go over the various components of the exam and what to look out for. Of course, you can also look this up yourself, but it's important to know what's normal, to know what's abnormal. And it's also very important to get a good sign out, both from us and from your own colleagues. One thing that we don't love as clinicians are what's called discovery rounds, where we walk into a patient's room and find a neurological abnormality that we didn't know about from our own reports in the morning. And that can be very stressful, and probably why I have as many gray hairs as I do. And it's also important to cross-reference the information you're given with our progress notes. We tend to do overnight, or the provider handoff tab, which will often have some of the exam abnormalities in one of the boxes there, and also tells you about diagnosis and pathology. And the pathology also, again, is important to know what you're taking care of. In our next talk, the third talk, we'll talk about some of the more common cranial diseases that you're going to see on your units. So I had this slide on the last talk I did. It goes over the various components of the exam and the things that incorporated into it. This is a very important slide to be aware of, and I'm going to follow this in terms of going over the abnormal findings. And the first thing we always tend to assess is how with it is the patient, right? ANO times 3 to 4, person, place, time, and situation. And when someone has an abnormal exam finding, they lose these in the opposite order. So situation, then time, then place, then person last. So you tend to know who you are better than you know what time it is. And if that's not correct in your exam, something's off about that. So it's typically in this order. Then, of course, we go into levels of consciousness. And while you and I are normal, the next 2 levels can be a little confusing. There's somnolence and there's lethargy. A somnolent person is just a sleepy person, and that means that if you poke them and you wake them up, they'll wake up and they'll follow the exam and they'll have a conversation with you. A lethargic person is much slower to wake up and they're a little slower to work with you, but they can usually stay awake through the exam, and then they'll probably fall asleep right afterwards. And these two can be as a result of medication or fever or recent surgery or other things. And that's something that you want to make sure wasn't there when you walked in, okay? The other 3, obtundation, stupor, and coma, are really more profound neurological exam changes, and something we'd want to know about as soon as possible. The obtunded patient typically really can't stay awake through your exam at all. They constantly just sort of fall asleep. You have to really poke them to get through the exam. And the stuporous patient just grunts and groans. And then, of course, coma's coma. So these are very different, significant pathologies, whereas the first 2 can be a little, kind of a soft call. And then, of course, we can also have just baseline confusion and delirium. You guys are all very familiar with that, with our sundowning elderly patients, or patients can be on Decadron, or they need to be on Decadron. That could be causing their confusion. If you look at a picture here, you have a picture of George Bush, but to be a little more modern, depending on your political tilt, they're both a little confused, aren't they? But confusion can be something that exists, may not necessarily be an abnormality. But if it's new, of course, I know you guys will call us because these patients tend to be unruly. And again, don't forget to cheat and make sure that, this isn't something that we already know about from our exam, or was, something that was or wasn't, signed out to. The cranial nerves are next. I talked about the cranial nerves last time. There's 12 of them. You don't have to memorize all of them, but some of them are more important than others. You're not going to typically assess someone's smell. And if that's an acute change, they'll probably tell you. The same thing with vision. They'll usually tell you like, oh, I can't see, or they can't read your name on the board. But the rest of these are pretty straightforward, and the exam is very quick. I went over the exam last time, but you take your light, your shine in both eyes, one and the other, then both together to make sure that they accommodate. Ask them to look left, up, down, upright, look all over. Tell them to smile, stick out their tongue, puff their cheeks, test for the sensory and the 3 different branches, and then ask them to shrug their shoulders, right? And that's it. That's the most of the exam. So it's pretty quick to do, and it's very easy to pick up on, especially abnormalities. And first one you're going to pick up on before anything is pupil size, right? So if you have a acute change in the pupil that's fixed and very large, you will know that. And usually that comes along with other exam changes, but nonetheless, and that's why you have to compare both eyes. And then you can have a sluggish pupil, and a sluggish pupil is different than a slow to respond pupil. A sluggish pupil is really spastic. It goes up and down like this. And that's the graphic here if it's playing here. Other things that you can expect to see with abnormalities are gaze preferences. Very often our patients who have injury already have this. Sometimes they can develop it. And if they develop it, that's a red flag. And it could be one eye or both eyes. And they typically look at the injury. They'll look at the problem. So they'll look at the right side because there's a problem on the right side of the brain. And that's a reason for immediate escalation. And you can ask them, you can assess this by asking them to look left to right, and they won't be able to bring, sometimes they'll come to the midline, but they won't be able to go all the way. So that's a gaze preference, partial, full. And facial symmetry. Facial symmetry is another one of those things that usually are pretty easy to pick up on. You look at the forehead wrinkling, you look at the eyebrow going up and down, you look at the nasolabial folds, is there a smile, even obviously check if it's, if they're even at rest, but typically it's pretty obvious once they smile. And, sometimes you can have a very subtle change, and that's something you can pick up on. And we've actually picked up on a stroke like that on an enrollment, I remember, just from a weird little droopy lip. Tongue deviation, pretty obvious. Sticks out to one side. They can't do anything different about it. That's cranial nerve 12. And facial sensation. Again, I think patients will probably recognize when they're numb. Sometimes scalp numbness after surgery is normal because we made a cut. But typically, they're numb. This will come along with other things like chewing and swallowing. That'll be pretty obvious. The next 2 parts are motor and sensory. I'm putting these together because unlike the spine exam that goes along dermatome, so you have a weak thumb or weak extension or weak toes, typically with cranial patients, this is more global, right? The deficit's either the whole side or hemiparesis or hemiplegia or the entire arm. It could be both, weak, paralyzed, and numb. Okay, they don't all have to go together, but they can. And typically they speak to, the problem speaks to where the lesion is, right? So upper cortex, if you have a problem on the left side, the right side's affected, but if you're at the brainstem or below, that's going to be on the same side. And again, we'll talk about that in the cranial pathologies aspect to, localize where those lesions are for you to understand. But it's important to assess weakness. You obviously go by the strength scale. This should be fairly common. The plus minus belongs a little lower down by the 4-5. And, that can be a change that you can pick up on. Sometimes it can be pretty subtle, and a pronated drift will give you that subtlety where you ask them to hold their hands out and you close their eyes and they sort of drift down like this. Okay, that's usually a sign of something going on in the brain specifically. And, again, maybe patient did or didn't have it before, maybe somebody didn't test for it. So it's something to know about. The other thing with motor and sensory is neglect, which is different from true weakness or paralysis. Neglect is where they simply don't know that that side exists. Very often, if you examine them on that side, they won't even respond to you because their vision's affected or they won't even know you're there. And they won't turn at you and look at you. They'll just sort of just wait till you come into their, to the side that does work. And very often you have to show them their hands, say, hey, move your fingers, and they might be able to do it. So it's not a true weakness. And if you pinch them, they'll actually move and they'll say, ow, but they don't realize that they have it. But all of these, acute changes, different from what you understood them to be, can be a sign of a stroke or hemorrhage or a seizure, which is more transient. So that's an acute change that you should be aware of and, of course, escalate. Coordination, reflexes, and gait. I put these together as well. This tends to reflect on cerebellum, as well as potentially just being weak. And the physical therapist will usually come to you and say, hey, this person's, walking like this or like that or like this guy. And, it's usually pretty obvious, but one thing that you'll pick up on is when they lean to one side, especially if you're taking them up to go to the bathroom, they tend to veer to one or they're holding on to something. And that could be a sign of neglect or paresis or, again, some of these gait issues. And you'll also pick up on dysmetria. Dysmetria is when you see people having trouble with utensils, they can't write very well, they can't button buttons. That's dysmetria. That's your coordination typically from the cerebellum. Reflexes, I don't really expect you to whip out a reflex hammer and start checking patellas, but just be aware that high reflexes or jumpy reflexes are a sign of, could be a spine or brain problem. And spasticity specifically, if you ever do see that, tends to be something that's chronic. So if it wasn't reported to you and a patient's just like contracted or spastic, like think Parkinson's patients, that tends to be chronic. It's not something that, just happened yesterday. Okay. This is a picture of a Hoffman sign. It's similar to what we do in the leg for clonus, right? I'm sure a lot of you know clonus. You can do the same thing on the hand. You can flick the finger and the thumb goes like this. That's a sign of an upper motor neuron or brain or high cerebral problem. The next is speech and swallow. This is where you as bedside nurses are really great at picking these things up. You'll pick these up before anybody else does. And they can be various. They can be an aphasia. And aphasias can be expressive, receptive, or both. Expressive is where they can't really get their words out to you. And they look very frustrated because they can think it. They just can't say it. And receptive, where they don't understand. They just stare at you blank. Like they don't know what you're saying because they have as a receptive aphasia, or it could be a mixture of both. And if it's not aphasia, they can have a dysarthria, which is slurred speech or me trying to talk to you right now, or word salad, and dysphagia with an S, which is just a difficulty or a slow response. Like they're not talking normal. They were before, but now they're not, right? That's typically what you walk into. And that can be dysarthria or dysphagia. Dysphonia is just a low volume speech where you just can't hear them. And dysphagia with a G is the patient that's drooling or choking or pocketing food. You'll usually pick up on that pretty quickly as well. A lot of these can be signs of a seizure or something going on, and it's definitely a reason to give us a call. So I had some of these pearls last time, and and just to go over the point of this whole thing is the abnormal exam. Some of it can be pretty obvious, but if you're not sure or the sign that you got wasn't clear, escalate it. And I say escalate it even for sassy, because sometimes we can be really sassy, especially if you call us and it's 3 in the morning. Don't worry about that. That's our problem, not yours. So when in doubt, just escalate. Cheat. Make sure you look at the handoff, you understand the diagnosis, that the exam was clear to you. If you're getting, best example I have is if you call me and tell me the patient's obtunded, I'm going to drop everything I'm doing and run over there. But if the patient's just somnolent and you just walked onto your shift and the family comes out to the patient's somnolent, well, take those 15, 20 seconds and examine the patient first to make sure that it reflects a change and not something that you already understood, but the family doesn't understand, right? Because again, that's a different workflow for us as clinicians on what we're doing. And, trust but verify. Even if somebody did sign out something to you, make sure you do your own part so that you understand what was being expressed to you. And try to use the terminology. Again, obtundation and somnolence are very different things in my mind when I get those calls. My brain's worried if I hear about something that's severe. This other box here is what I think would be the earliest exam changes that you would walk in on. And I think these are, and so this is like a short list of things to remember. Of course, changes in wakefulness and consciousness, that can be really, really obvious. They're awake, now they're not. This is different. Pupil changes, if you walk in on them, they aren't awake, check their eyes, see if the pupils are different, if they're spastic and sluggish. Check if their face is the same. Droopier face can be a sign of something going on. Check when you're checking their pupils, see if they have a gaze preference, see if they're looking one way or the other. Right, that can be very, very, very obvious. And check for weakness or neglect, and of course, aphasias, dysphasias, and any other changes to speech. And that is it. Thank you very much. Next time, Farhana will talk to you guys about some of the cranial pathologies, and then we'll have Lauren talk to you about some of the wound care components of our patients. And this is just more pictures of me sleeping like last time. Thank you very much.